Mr. C was admitted to acute care rehab after spending 6 weeks in the trauma ICU status post motor vehicle collision. He has a diagnosis of traumatic brain injury, specifically a subarachnoid hemorrhage and right frontal lobe contusion. He is status post EVD placement for ICP monitoring, which has now been removed. Patient was intubated with NG tube feedings, and he is now status post trach and peg. He has no significant past medical history. It is estimated that MVAs are responsible for approximately 14% of traumatic brain injuries. A subarachnoid hemorrhage is bleeding into the subarachnoid space, which is the area that is between the brain and the tissues covering the brain. When blood vessels on the surface of the brain rupture due to a traumatic event, the blood mixes with cerebral spinal fluid, and this spreads throughout the subarachnoid space. Management of these types of bleeds include close neurological monitoring, anti-seizure medication, ICP monitoring, and in severe cases, an external ventricular drain may be placed to manage high ICPs. The brain swelling and reduced level of consciousness often require intubation, therefore tube feeding is usually indicated, and in some cases, tracheostomy and peg placement are needed. Acute care rehab is for patients who can withstand the rigors of daily intensive therapy. Acute therapy sessions usually last 3 or more hours per day, 5 to 7 days per week. Patients receive a combination of physical, occupational, and speech therapy. Other members of the rehab team include nurses, dietitians, social workers, recreational therapists, and neuropsychologists. A multidisciplinary healthcare approach gives patients a continually evolving goal that improves their function and quality of life until they can transition to daily life without therapy. Mr. C was admitted to acute care rehab with a treatment plan of 3 hours of therapy per day, 7 days per week. He has been on a continuous tube feeding via PEG, and there is a physician consult for nutrition assessment. Mr. C is 5'9". His current weight is 168 pounds, and although he is 105% of his ideal body weight, he has had a 12-pound weight loss or a 7.2% weight loss over 1.5 months or 6 weeks. His glucose is slightly elevated along with his BUN and creatinine. His albumin and prealbumin are both low, but his CRP is high. And the etiology of his low albumin and prealbumin is likely multifactorial, including the inflammatory response. Malnutrition cannot be ruled out with his recent weight loss. Mr. C was admitted to acute care rehab on a continuous tube feeding of impact peptide 1.5. Now that he is on rehab, an immune-enhancing formula is no longer indicated, so my recommendation was to change to Jevity 1.5. I also recalculated his needs, and according to the Aspen guidelines, I used the higher end of his calorie and protein needs. The current tube feeding formula with impact peptide is providing 110% of his calorie needs, 148% of his protein needs, and only 81% of his fluid needs. I also recommend a change to a bolus tube feeding because he is going to be doing intensive rehab and will not be able to do continuous tube feeding with a pump and a pull while doing rehab. So I recommended to change to Jevity 1.5 bolus tube feedings Q4 hours. And I also increased the water flush. His fluid needs were being met in the ICU with the IV fluids, but now that those have been discontinued, we need to increase the free water. On day 7, I received another consult to reassess the tube feeding. Patient had a video swallow study and was safe for a pureed with honey thick liquid diet. Patient has been tolerating the bolus tube feeding well with no GI symptoms. I recommended to change to a cyclic tube feeding or a nocturnal tube feeding that will run for 10 hours at night. This will help to improve patient's appetite during the day so he can have optimal PO intake. The cyclic tube feeding is going to meet 60% of his needs, and I also recommended starting Magic Cup Supplement BID, which is a level 4 consistency. On day 14, I did a reassessment of Mr. C. His diet has been advanced to mechanical soft with nectar thicks. He's eating 100% of his Magic Cups and meeting 50 to 60% of his needs with his oral diet. He's had a desirable 6-pound increase, and his labs have also improved. I recalculated his nutrition needs and recommended to taper the cyclic tube feeding. So it will run at 80 mLs an hour for 8 hours at night. This cyclic tube feeding will meet approximately 43 to 44% of patients' estimated needs. On day 17, Mr. C was advanced to a regular diet with thin liquids. He's been consistently meeting 75 to 85% of his needs, so I recommended to discontinue the tube feeding. On day 19, the PEG tube was removed, and on day 21, Mr. C went home on a regular diet with thin liquids. On day 1, when Mr. C was admitted to acute care rehab, his glucose was slightly elevated, and this was likely due to metabolic stress and being in the ICU. By day 14, it had improved. His elevated BUN and creatinine also improved, and this was likely due to the change to a lower protein tube feeding formula and recalculating his protein needs, as well as increasing his water flush. Although his albumin remained low, his prealbumin improved from 14 to 22 on day 14. Mr. C also had a desirable 6-pound weight gain during his rehab stay and was 97% of his usual weight on day 14. On day 1 of rehab, Mr. C was changed from continuous to bolus tube feeding to enable him to do therapy without the inconvenience of a pump and a pole. On day 7, he had a video swallow study and was started on a pureed diet. We changed to cyclic tube feeding to allow for optimal intake during the day and tube feeding at night. On day 14, his diet was advanced to mechanical soft. He was consistently meeting 50 to 60% of his needs, so we tapered his cyclic tube feeding. On day 17, his diet had been advanced to regular with thin liquids. He's consistently meeting 75 to 85% of his nutrition needs. I recommended to DC the tube feeding. On day 19, his PEG tube was removed, and on day 21, he went home on a regular diet with thin liquids.